Hi, I'm Rose Villeneuve. I'm a nurse practitioner at Grand Itasca. I work in the internal medicine department, and I also specialize in wound care. I was recently wound care certified and actually have been managing wounds for approximately 8 years now, and have been working at Grand Itasca for the past 15 years in primary care with internal medicine. So we'll get started on our topic. We're going to discuss caring for your wounds. Objectives for tonight: understand anatomy. Is the wound acute or chronic? Understand pressure wounds, types of lower extremity ulcers, arterial, venous, and diabetic, and causes and treatments for wounds. Some of the pictures here are rather graphic, just to warn you, there are going to be some open wounds that are shown, so if you have a sensitive stomach or don't want to look on certain slides, just feel free to look away. First, we'll discuss anatomy. The skin, it's the largest organ of the body. The functions of skin is to protect against bacterial invasion and other external factors, including water, chemical and mechanical, bacterial and viral, and ultraviolet radiation. It prevents excess fluid loss, and it produces an oil called sebum, which gives the skin additional protection from outside forces. It retains water and maintains body temperature. Layers of skin: epidermis and the dermis. The epidermis is the outermost layer of the skin. It is composed of millions of epithelial cells. The functions of the epidermis: it is a barrier against toxic substances. It prevents water loss and repels water. The dermis supports and nourishes the epidermis. It's highly vascularized, which means that it contains many blood vessels. The dermis contains nerves, sweat glands, oil glands, hair follicles. It fights against harmful bacteria and other microorganisms. And it also regulates body temperature. Subcutaneous tissue, as most of us also have known as fat tissue. It lies underneath the dermis. It contains lymph vessels and deep blood vessels, and brings nutrients and oxygen to the dermis through tiny blood vessels. Muscles. There's approximately 650 muscles in the human body. The primary job is to move the body. Bones. There's 206 bones in the body. The function of bones is to support and to protect our organs. So now on to wounds. We have acute wounds and we have chronic wounds. An acute wound heals more quickly, causing minimal function loss in the part of the body that is affected. It occurs secondary to surgery or to trauma, and usually will heal within 4 to 6 weeks. Surgical wounds typically are managed by a surgeon, so it's recommended that all post-operative follow-up appointments are kept by patients, because this is very important for the surgeon to watch the wound to make sure it's healing appropriately. You should contact your surgeon's office if you notice any of the concerns or possible complications, such as the wound opening, redness or warmth, purulent drainage, increased pain, and fever. Now on to chronic wounds. Some statistics regarding chronic wounds. Between 1 and 1.5 of the industrialized population suffers from problem wounds. That is almost 67 million people. This represents a significant burden to patients and to families, healthcare professionals, and the United States healthcare system. It can lead to severe infection, limb loss, and death. So how do we recommend that you manage simple traumatic wounds? You should manage those through cleansing the wound daily with a gentle soap, rinsing the wound with warm water and just patting it dry rather than vigorously rubbing it dry. Cover the wound with a thin layer of antibiotic ointment, then a bandage that is usually large enough to cover the entire wound and to also absorb all the drainage. That should be changed once a day. You should not use any harsh soaps nor antibacterial soaps. And the reason why is because antibacterial soaps and some harsh soaps are alcohol-based, which can cause stinging and irritation to the wound bed. That can then prevent the wound from healing in a timely manner. You should not apply hydrogen peroxide nor any alcohol cleansers to the wound. Once again, that causes drying of the wound bed and can lead to a scab formation, and it can delay healing and lead to a chronic wound. Managing chronic wounds. Effective management only occurs when treating the underlying factor that caused the wound to become chronic. So for example, is the chronic wound caused by pressure? Has it become chronic because it's too moist? Is it infected? Or does it have an impaired blood supply? Pressure wounds. Pressure wounds are also known as bed sores, pressure ulcers, and decubitus ulcers. 1.7 million people develop pressure ulcers each year. The average cost of treatment per pressure ulcer is between $5,000 and $60,000. They're caused by prolonged pressure and typically occur over bony prominences in bed or chair-bound individuals. They may also occur from friction or shearing of the skin, and may occur in mobile individuals from prolonged sitting or to other surfaces of the body that are not repositioned periodically. 95% of pressure ulcers occur over 5 classic locations: the tailbone and pelvis, hip, buttocks, outer ankle, and the heel. And this little chart here basically just shows you the bony prominences that, depending upon the position that a person may be lying in, that's going to be most affected by pressure. Extrinsic factors. Number 1 is pressure. This is compression or squeezing together of soft tissue over bony prominences caused by weight or tension, which causes blood vessels to collapse, reducing blood flow to tissue, and potential causing tissue death. The depth of the wound is directly correlated with the extension of damage to the underlying layers from lack of blood flow. Depending upon the health and age of the individual and a few other factors, tissue ischemia and death begins within 2 to 6 hours of sustained pressure. Tissue death is irreversible. Friction. It's the force of 2 surfaces rubbing together. For example, that would be the back rubbing against a bed sheet when being moved upward in a bed. Shearing is the combination of friction with gravity leading to skin disruption. Causes stretching or tearing of blood vessels, leading to tissue injury. That would be a person sliding downward while sitting in a bed with the head of the bed elevated. Moisture. It causes softening and maceration of the skin, which leaves the skin's integrity more susceptible to the forces of shear, pressure, and especially friction. Moisture can also break down the skin's defenses, leading to incontinence-associated rash and yeast infection. So for example, urine and fecal incontinence, and also sweating can do that. So intrinsic factors. Nutrition. Protein deficiency causes malnutrition, which allows soft tissue to be more susceptible to skin breakdown. Low protein reduces the pressure system that holds fluid into the blood vessel, allowing it to leak into the tissue, compromising oxygen and nutrient transport to tissue. Age. Skin becomes thinner with age due to a reduction of collagen production. Muscles shrink and bones also weaken with age. Low blood pressure. Blood pressure that is too low can shunt blood from the skin to more vital organs, such as the heart, kidneys, brain, and liver. Tissue oxygen, infection, and comorbidities, including heart disease, emphysema and other lung disease, and diabetes. Other risk factors are smoking, weight loss, and when we say weight loss, that's a tremendous amount of typically unexpected weight loss. Elevated body temperature and surgery. So stages of pressure ulcers. Pressure ulcers are staged by the extent of the injury to the affected tissue. Stage 1 is intact skin with redness that does not blanch with pressure, usually over bony prominence. It may be painful, soft, firm, warmer or cooler than the surrounding tissue. Stage 2 is a partial loss of the dermis, causing a shallow open ulcer with a red-pink wound bed, and it also may start as a blister. Stage 3, that would be a full thickness tissue loss that extends into the fat layer and may see visible bone, muscle, or tendon, and those are very painful. Stage 4 is a full tissue loss with extending into bone, tendon, or muscle. Osteomyelitis, which is a bone infection, can occur at any stage, but most commonly will occur at the stage 4 because of that exposed tissue. They're very difficult to treat and to get rid of a bone infection. Usually several weeks of IV antibiotics are needed, and frequently amputations may need to occur. There are pressure ulcers that are considered unstageable. These typically have a full tissue loss with too much slough or eschar. Those are basically dead tissue that's inside the wound, and it covers the wound bed. When it's unstageable, it needs to be debrided, which means that it needs to be cleaned out with a scalpel or scissors by either a wound care specialist, or if it needs extensive cleaning where possibly healthy tissue also needs to be removed, then the patient would be referred to a surgeon to have that completed. Once that's completed, then healing can begin to occur. So treatment of pressure ulcers. We start to treat those initially with hydrocolloids depending upon the depth. A hydrocolloid is a thin adhesive dressing that forms a skin barrier and allows for self-debriding. And I did bring an example of one. You're welcome to look at these afterwards. Typically it has a soft side and a sticky side, and this goes directly over the wound, and it can be cut a little larger than the wound. A padded outer dressing, such as a foam or an ABD pad. A foam dressing is similar to this. As you can see, it's padded. It can absorb a lot of fluid, and these come in many sizes. Typically the largest size is about 6 inch by 6 inch, and then you can cut them to a smaller size if the wound is smaller. There's absorbent primary dressings. Which I mean by a primary dressing is that type of product would sit directly on the wound bed. That may include a calcium alginate or a packing gauze. This is an example of a calcium alginate, and these come in larger sizes. They are cut to fit directly inside the wound, so all the wound bed's covered. And this little dressing can absorb about 30 times its weight in fluid. So they're great for absorption. And then we have packing gauze. This is one form of a packing gauze, and it can be cut more narrow, and then you cut as much as you need. You pack it into a wound. Typically we use these for wounds that have some drainage but not a large amount of drainage, but typically those wounds are more of a narrow opening where it's almost like a tunnel, and alginates wouldn't come out of that easily, so we typically pack with this type of dressing. We also may use a wound gel and topical antibiotics. Most importantly, pressure prevention is the key to avoiding pressure ulcers. Pressure elimination, that can be done through frequent repositioning, every 15 minutes to reposition a person's self, or turn and reposition an immobile person every 1 to 2 hours. Support surfaces for beds, wheelchairs, and recliners can be used. Also, placing a pillow between a patient's knees, or your own knees at nighttime if you tend to sleep with your knees together and that causes pressure, that can help to prevent that pressure. And also offloading the heels and ankles from the bed and other pressure areas. A lot of times a simple way to do this is just putting a pillow underneath the calves and just letting the heels float freely. Now to lower extremity ulcers. Arterial ulcers. Arterial disease affects more than 8 million people in the United States every year. Approximately 10% of all leg ulcers are related to arterial disease. Primarily the outer ankle and the toes are affected. Most common cause is atherosclerosis, which is clogged arteries. It can be caused by trauma and have the inability to heal because of a reduced oxygen-rich blood supply. They can typically begin as dark black spots on the skin, as you can see here on this toe. It's just a black spot. And that's basically where the tissue has died because of a lack of oxygen-rich blood. Other arterial ulcers will have a pale pink dry wound bed due to lack of oxygen-rich blood flow. And here's other common locations, such as the bottom of the toes, tops of toes, pads of the foot, and the heel are commonly affected by arterial disease. Treatment for arterial ulcers. The way to determine if a patient has arterial disease, one simple test to do is called an ABI, which is an ankle brachial index. It's an ultrasound type study used to determine the amount of arterial blood flow. Any type of compression stocking and leg elevation needs to be withheld until an ABI is completed, as both these can worsen arterial blood flow if you compress it or if you elevate it. Wounds with mild reduction of blood flow may still heal, but process is slow and they're at an increased risk of infection. It's best to hydrate these wounds with wound gels and to cover with an appropriate secondary dressing. Venous ulcers. Most common of lower extremity ulcers. They affect approximately 1% of the United States population, and they occur due to improper functioning valves in the veins. So what I mean by improper functioning valves in the veins is that your veins move blood from your extremities back up to your heart, and the veins have little valves. The purpose of those valves is to push that fluid, the blood, what I call fluid, to push it back up, and to also keep it up so it doesn't drip downward. And those valves can become leaky, and whenever they do, that's when blood typically pulls down, and that's why you'll see a lot of times patients will have large swollen legs for that reason, because of bad veins. People with venous disease usually have swelling in the legs and dark brown skin over the lower legs. They usually drain large amounts of fluid and have a pink or yellow wound bed. Compression and fluid management are important for treating these wounds. Elevation to reduce the swelling in the legs is also important. Using absorptive dressings. The change frequency is determined by the amount of fluid the wound drains. And as we had talked before, typically we use the calcium alginates, which is that dressing that absorbs all the fluid. The foam dressing, which also absorbs large amounts of fluid and also protects the wound. There's also a treatment called an Uniboot, which is interesting, and it's changed by a wound specialist usually once or twice a week, depending upon the amount of drainage that's coming from the wound. And the Uniboot is a 3-layer wrap typically. It can have more layers depending upon how much swelling there is in the leg and how much drainage there is. If you compress it, then you have less drainage. So the first part of an Uniboot is this moist layer. And it has a medicated paste that goes right directly on the skin. And it's a wrap that starts at the foot and goes up to just above the cast. And usually within about 24 hours, this will firm and almost form a cast, but not as restrictive as a cast and not as firm as a cast. The next layer would just be a Curlex, just a gauze roll layer. And this helps to absorb some of the fluid. And last would be the Coban layer. And this is kind of a stretchier layer that can help you add more compression or less compression. And once again, these are usually changed once or twice a week. There's also certain procedures that can be done to help to fix those veins. One of the procedures that we do at Grand Itasca, our radiologists do this procedure. It's called the closure fast procedure. This procedure, what it basically does is the radiologist does an ultrasound of the leg, and they determine which vein is malfunctioning, so which one is leaking and causing the wound or all the swelling in the leg. And then they'll take a small catheter and insert it into that vein and then apply heat, and then it burns that vein and it shuts that vein down. So then that blood just reroutes to a larger vein, is how that works. Doing this procedure can help speed up wound healing and can also help to prevent recurrence of venous ulcers. So I'm sure some of you are thinking, what do you do if you have both bad arteries and bad veins? Well, then you're a difficult patient to manage. So this occurs in patients who have both arterial and venous disease. Healing can be tricky with modifications needed to care for both disease processes. And treatment selection is determined by the needs of the wound. A lot of times patients who have arterial and venous wounds, their wounds are quite complicating because you have a large amount of fluid typically coming from the wound, but then you can't do any compression because then you could restrict the blood flow for the arteries. So a lot of times with these patients especially, we'll need to send them to a vascular specialist, and then they'll have to have their arteries evaluated and see if there's any procedures that can be done to improve that arterial blood flow. And then once that's done, then typically the patient comes back to me and then we just manage the wound until it heals. Diabetic ulcers. Every 30 seconds, a leg is lost to diabetes somewhere in the world. 40 to 70% of all lower extremity amputations are related to diabetes. 85% of all diabetes-related amputations are preceded by foot ulcers. Researchers have established that between 49% to 85% of all amputations can be prevented. Causes of diabetic ulcers. Peripheral neuropathy. This is a complication of diabetes where the foot loses sensation and does not feel damage and injury. There's a greater risk of arterial disease in patients with diabetes. There's an increased risk of infection. And pressure can develop because of changes in the foot shape caused by increased pressure over the metatarsal heads. It's very important for patients who have diabetes to have properly fitting shoes. Location of diabetic ulcers. Typically, they're on the bottom of the foot, over the metatarsal heads, underneath the heel, and on the toes. Characteristics of a diabetic ulcer. They're usually painless. They have even wound margins. They're either round or oblong shaped over a bony prominence. They're deep. Typically, they have a callus surrounding them. They can develop a skin infection called cellulitis, which is infection around the skin of the wound, and they can develop into osteomyelitis. Occasionally, I'll see a patient that the first time I see the patient, they happen to notice a wound and I can already see the bone. That's why it's very important for patients with diabetes to check their feet every day and to not walk on any surface barefooted and to wear diabetic shoes. Also, another thing is if you're diabetic and you start seeing calluses on your feet, that's an indicator that there's some friction and rubbing on the foot and that your shoes are not fitting properly. Those calluses typically turn into diabetic ulcers. Treatment of diabetic ulcers. Total contact casting, which is also known as offloading. This basically is what it says. It's a cast that we can put a patient in, and then the patient has a walking boot that goes on top of the cast, so then they can move around freely. It's changed once a week in the clinic. Diabetic ulcers typically need to have sharp debridement, which means that the callus and dead non-viable tissue needs to be removed. Occasionally, we'll see diabetic ulcers that has what's called a dry, stable eschar. A lot of times, these will be located over the tips of the toes and the heel. And the way to best describe this is it's a very thick, dark scab. What that does is it actually protects the underlying wound. And sometimes we don't want to remove those if they're stable, because then you can open up a wound and it can be more difficult to heal, leading to more problems. But those are the only two cases, is if they're on the toes or on the heel, that we may leave that in place. A lot of times we do remove them if they're not stable, so if they're soft, if there's any opening, if there's any drainage, we will need to remove them. It's important for patients for diabetes to have type diabetic control. If a person's running high blood sugars, it increases their risk of developing infection and also decreases the chance that they're going to heal properly. Treatments for diabetic ulcers would also include foams, alginates, silver-infused dressings. Silver is an antimicrobial that can be infused into a dressing and can help prevent secondary infections of the wound. There's also a topical ointment called Regranix. It can help diabetic ulcers to heal, but it's very expensive. Prevention of diabetic ulcers. As I said before, proper fitting shoes, and also getting an annual diabetic foot examination every 3 months if the person has peripheral neuropathy. Then they need to have their feet checked by their doctor. With that examination, what the provider checks for is a protective sensation, the structure and biomechanics, vascular status, and skin integrity. Conclusions. Keep all wounds clean and covered. Moist wound healing is best for expediting wound healing. Seek care with a wound specialist for any wound not healed in 4 to 6 weeks, and see a medical provider immediately with any sign that a wound may be infected. Well, thank you for letting me talk tonight. I enjoyed it.